Will everyday investors and shareholders shake the foundations of capitalism by seeking a greater voice in corporate boardrooms? Join Chicago Booth's Rustandi Center and Stiegler Center in partnership with the Financial Times for a virtual event on June 14th. Shareholder Democracy: Is a Revolution on the Horizon? Is the second in the Unpacking ESG series featuring Chicago's Luigi Zingalis and University of Pennsylvania's Lisa Fairfax. The panel will be moderated by the FT's Simon Mundy. Register at chicagobooth.edu/unpackingESG. How can we improve communication at work? Are stock markets really efficient? Should we let algorithms make moral choices? How will climate migration affect our societies? The Chicago Booth Review podcast addresses the big questions in business, policy, and markets with insight from the world's leading academic researchers. We bring you groundbreaking research in a clear and straightforward way. It could help you make better decisions, work smarter, and maybe even become happier. Find us wherever you get your podcasts. If there is something that both sides of the political aisle can agree on, it's that there is something deeply wrong with healthcare in the United States.
One thing that experts across the political spectrum agree on is that healthcare in America often costs too much.
And while everyone may agree we have a huge problem, what they can't agree on is how to fix it.
President Trump knows that every day Obamacare survives is another day that American families and American businesses struggle.
The United States of America, our very great country, is the only nation in the entire industrialized world that does not guarantee health care to all people as a right.
It feels as if we've been on a never-ending merry-go-round since 2010. The right blames everything on the Affordable Care Act, even though they can't muster the votes to change it, while those on the left say we need health care for all, even though it's politically outside the realm of possibility.
Democrats imposed Obamacare on our country. They said costs would go down. Costs skyrocketed. They said choice would go up. Choice plummeted.
Look at the business model of an insurance company. It's to bring in as many dollars as they can in premiums and to pay out as few dollars as possible for your health care. That leaves families with rising premiums, rising co-pays, and fighting with insurance companies to try to get the health care that their doctors say that they and their children need. Medicare for All solves that problem.
Meanwhile, Americans are stuck in the middle.
I think anyone designing a healthcare system from scratch would not design the system that we have.
That's Katherine Baicker, one of the leading health economists in the world. She serves as provost of the University of Chicago and previously was dean of the Harris School of Public Policy.
The share of people who would say that they like our healthcare system is going down and down and down for good reasons, and maybe it's a moment where we can actually think about transformation to a different system.
And that's exactly what Baicker has done. In a recent paper published in the Journal of the American Medical Association, or JAMA, she has laid out an innovative blueprint for healthcare in the U.S., not to tinker with our system on the margins, but to redesign the entire thing.
What I worry about with incremental changes is that they continue to build on this increasingly dysfunctional system in a way that bakes in some of the problems that we have. So if we approached health reform from a different vantage point, rather than trying to patch tiny holes in a very, very leaky healthcare system, one by one by one, I think that we could not only achieve a more efficient system, but we could also have more rational decision-making about what our public policy priorities are.
It's a fascinating idea that takes us through the complex history of health insurance, how that web got so tangled up today, and how we can straighten it out.
And I think implementing a transition plan that is thoughtful about continuity of coverage, continuity of care, smooth transitions over years, I think would be crucial for the success of introducing these elements that we're talking about.
And with tens of millions of Americans uninsured in an era of ever-declining health, the stakes have never been higher.
We have much higher rates of obesity and heart disease. We come into the healthcare system a lot sicker in many cases than people in the European countries that we're being compared to. So it costs more to take care of us.
Welcome to Big Brains, where we translate the biggest ideas and complex discoveries into digestible brain food. Big Brains, Little Bites, from the University of Chicago Podcast Network. I'm your host, Paul Rand. On today's episode, a new way to design health insurance in the United States. Well, before we get into your latest JAMA piece, why don't we just go back a little bit, Kate, and tell me what initially caught your fancy on healthcare policy and economics?
So I've always been interested in how we can structure public programs to make the safety net as robust as possible and to be able to afford all the programs we want for housing, for healthcare, for schools, for food. And the way we structure those public programs makes such a huge difference in people's lives. I started out as a public finance economist, really caring about how we make sure we have the resources for public programs. But once I started studying the U.S. healthcare system, it's so complicated and it's so vitally important, but has so many areas where it's not living up to its promise. I decided that's where I wanted to devote my efforts.
Well, and in your JAMA paper, you take a bit of a historical perspective here. So why don't we start there and talk to me about health insurance in the United States and how we kind of got from where we were to where we are. There's 10% of the population is uninsured right now. Is that right?
So almost 10% of the population in the U.S. is uninsured.
And if you think about that in coverage in relation to other developed nations, how does that 10% figure, or in our case, it's about 33 million people, how does that 10% add up in relation to others?
We are way above other developed countries, our OECD trading partners, in the share of our population that's uninsured. Most developed countries have driven that number down to near zero. A natural question is, why are these people uninsured? Why are they falling through the cracks of our system? Well, there are a lot of different reasons. A lot of it comes down to this wacky patchwork that we have of private insurance and public insurance. And why is the system set up the way it is? Well, it goes back to some decisions that were made around World War II and even before. Back around World War II, there wasn't a lot of private insurance in the U.S. or anywhere else.
We are rightly proud of the high standards of medical care we know how to provide in the United States. The fact is, however, that most of our people cannot afford to pay for the care they need.
Because of some price and wage controls that were in place around World War II in the U.S.,
we shall be compelled to stop workers from moving from one war job to another as a matter of personal preference, to stop employers from stealing labor from each other.
It became attractive for employers to offer health insurance as one of the benefits of working, in addition to wages and anything else. And there was a decision that those benefits weren't taxable, unlike your wages. And that baked in a system in the U.S. where a lot of our health insurance comes through our jobs. Most people who have private insurance in the U.S. get it through their employer or their spouse's employer or their parents' employer. And that really accelerated during that 1940s, 1950s period. Well, one of the problems is that when you retired from your job, you lost your health insurance.
The Harry S. Truman Library at Independence, Missouri is the scene of an historic event. President and Mrs. Johnson and Vice President Humphrey arrive for ceremonies that will make the Medicare bill a part of Social Security coverage.
So Medicare came in 1965 to cover people who were otherwise going without vital care and losing their homes and their families' well-being when they got sick. So before the advent of Medicare, which covers people over age 65 in the US along with some others, older people who had retired, who were at the period of their lives where they needed healthcare the most, usually didn't have insurance. And so an expensive illness would not only mean they didn't get the care that they needed, but would bankrupt them and their families.
The new bill expands the 30-year-old Social Security program to provide hospital care, nursing home care, home nursing service, and outpatient treatment for those over 65.
Then, everything changed in 2010.
Today, after almost a century of trying, today, after over a year of debate, today, after all the votes have been tallied, health insurance reform becomes law in the United States of America.
With the advent of the Affordable Care Act, or Obamacare, millions of people who had been uninsured got insurance, either through Medicaid or through subsidized health insurance exchanges or through their parents' plans.
And today, the ACA hasn't just survived, it's pretty darn popular. And the reason is because it's done what it was supposed to do. It's made a difference. First 20 million, and now 30 million people have gotten covered thanks to the ACA.
And that really cut the rate of uninsurance, but it didn't cut it to zero. There are still millions of uninsured people in the US. So now we have this system where privately insured people are getting their insurance because of their jobs. And older people are getting their insurance through Medicare. And low-income people who don't have insurance through their jobs may or may not be getting it through Medicaid, which varies a lot state to state. So we have an incredibly patchwork system. And there are a plethora of other programs, including the Children's Health Insurance Program, or CHIP. There's in care for veterans through Veterans Benefits, and active military through TRICARE. So there are all of these different programs. And the rules for Medicaid vary state to state. So what insurance you have depends a lot on where you live and what your income is and what your family structure is like, and that is not good for continuity of care. So almost 10% of the population in the US is uninsured. There are some groups that are excluded from many avenues of coverage, like undocumented residents, like low-income people in states that have not chosen to expand Medicaid. So there's some groups that are not eligible for some of these programs, but a huge share of the people who are uninsured actually are eligible for free or very low-cost insurance, and they're not enrolled. So it's not just about affordability, it's about other things too.
Do we know from your research if there's an overwhelming set of reasons why they've chosen not to be insured?
People have been studying this question from lots of different perspectives. So there's a body of research that suggests that some of it is about lack of information. People don't know what plans are available to them and how much they really cost. Some of it is about non-financial barriers to enrollment, the required documentation to show that you are income eligible and citizenship eligible and all of those categories, or the paperwork that's necessary to take advantage of those benefits. Some of it may be about misperceptions about the value of health insurance itself, because on any year when you're not using health insurance, anything you pay for a premium seems like it's wasted because it's providing financial protection against something that didn't happen.
All right, so then there are political and financial pressures that step in to make this more complicated. Talk to me about what, if any, are the political pressures that make this situation challenging.
Well, I am a simple economist, and so the realm of politics is often baffling to me. And there are lots of examples of where the political system or forces outside of economics seem to be keeping us where we are. For example, the Affordable Care Act, or Obamacare, let states expand Medicaid eligibility to all of their population that was under 133% of the poverty level, which many states had not done in advance of that law. And the federal government picked up the vast majority of those costs. So if you are a state governor or legislator, Your choice is, would you like to give low-income people in your state insurance that they don't currently have, paid for by the taxpayers in other states? The Economist would say, yes, please. Yet many states chose not to expand Medicaid. And that shows that it's not just about the economics. It has to be about ideological concerns, the politics, other things that are at play. It's also become increasingly difficult to get through modest health reforms that almost everyone would describe as common sense. There are some glitches in the ACA or Obamacare as originally constructed. Incompatible definitions of income based on individual income or family income, notches in eligibility that were never intended by the legislation. In times where there was reasonable cooperation across the aisle, I think that these would be seen as common sense technical fixes. Yet it is almost impossible to get anything like that done right now. And if you look at the history of Medicare, where we started, this is a more than 50-year-old program, has been amended countless times because it is incredibly complicated and there's always something that needs addressing. If you live in a world where you can't do technical fixes in a sector that accounts for almost a fifth of the economy, that is a problem.
And so there is a cost, of course, when we have so many uninsured people. What is that cost?
First and foremost, the cost is to the uninsured. When you have health insurance, you have access to more health care, to higher quality health care, you get health care earlier, you have better health outcomes, you have greater financial security. It is much, much better to be insured than to be uninsured. To me, that's the main cost of uninsurance.
But there are also costs imposed on our system by having such a high number of uninsured people. Uncompensated care, or the care received by uninsured people that is never reimbursed, is roughly $40 billion annually.
There are many people who fall through the cracks. It poses an incredible administrative burden on healthcare providers to have to deal with so many different insurers. It is wildly inefficient in many ways.
You also talked in your paper about this idea of it being a problem with something called job lock, and I wonder if you can explain that for us.
The real problem that became incredibly salient during the pandemic is that if you move jobs, if you lose your job, if you retire, you risk losing your health insurance. And that makes it very costly to leave your job. So some people who are in jobs that are not the ones they want, that are not a good fit, that are not working out well, stay just because of the health insurance. Because if they went to get a new job, they might not have any insurance at all, or they might face much higher premiums. That stickiness in your job because of your health insurance is called job lock. And it means that not only are health insurance markets not operating efficiently, our labor markets aren't operating efficiently.
And we all pay a price for that lack of efficiency in lost wage gains, decreased economic output, and new businesses that may never be started. But that's not all. Our current system also warps the incentives of insurance markets, which could be affecting the health of even those with insurance.
Yes, so much of our long-term health outcomes are based on things we do over many years and healthcare that we get over many years. In our current system, you're not insured by the same insurer for all that long. And when you turn age 65, usually you switch over to Medicare. So if you're an insurer of a population that is, say, 45 to 65, there are really limited incentives to invest in that population's health in a way that will forestall the heart attack that would occur when people turn 70. So no insurer has a long-term relationship with you to invest in your health for the long term. If we instead had a system where insurers were paid based on how well they managed a population's health, if they lowered your risk of a future heart attack, that's good healthcare. Whether you have the heart attack, whether you would have had the heart attack at age 70 or 75, it's good healthcare for lowering your future risk. And it would be great to have a healthcare system that incentivized that kind of investment.
Obviously, this system is broken in so many ways, but solutions are few and far between. The most prominent is the idea of moving to a Medicare for All system.
There's a lot of conversation about Medicare for all and having that as a mechanism for universal health insurance. What we propose instead is the idea of a basic insurance plan for all.
That plan after the break. Are companies that support ESG principles driving their own political agendas, or are they looking out for the long-term interests of shareholders? Join Chicago Booth's Rustandi Center and Stiegler Center in partnership with the Financial Times for a virtual event on June 21st. Is corporate ESG woke capitalism? Is part of the Unpacking ESG series. Panelists include Chicago Booth's Marianne Bertrand, former SEC Chairman Jay Clayton, Lafayette Square founder and CEO Damien Dewin, moderated by Financial Times' Patrick Temple West. Register at chicagobooth.edu/unpackingESG. Fixing our broken healthcare system can seem like an almost impossible task, but building a new one feels even more daunting. So what does Baicker's basic insurance plan for all look like?
As a society, we decide on an amount of health insurance that we think everyone should have access to, a floor for access to healthcare. Now, we can decide how high that floor should be. When I describe it as a floor, it sounds minimal. It can be at any level of access to healthcare, but we decide collectively we want to make sure everybody has at least this much healthcare. Above that, people could then buy additional healthcare out of pocket or through wraparound insurance plans and have access to more services. But people would be guaranteed universal access to that basic policy. And importantly, enrollment would be automated such that there wouldn't be those non-financial barriers to care, in addition to there being no financial barriers to care.
This sounds like how I always understood the concept of universal health care. Is it the same thing?
There are a lot of problems, in my view and my co-author's view, with Medicare for all policies, including the risk of shortages of care or limited access to care, skyrocketing expenses, really tough decisions for a monolithic insurance policy that might not meet the needs of a very diverse, heterogeneous population. The difference is, I think a lot of people mean all available healthcare for everyone when they say universal healthcare. And people often come to that by asking the very important question, is healthcare a right? I think that question is ill-posed. You didn't say it, I said it, but I think it's an ill-posed question because healthcare is not one thing. Healthcare is a continuum of things, from the very high value to the very low value, sometimes even harmful things that happen to patients. If you said, I want public insurance to cover all possible care for all possible people, that is more than 100% of GDP. That leaves no money for food or education or housing or anything else.
Okay, wow.
So you have to make some decisions about what is covered in your universal insurance product. And even countries that have universal public insurance, as a lot of the other developed countries do, actually have something that sounds a little bit more like what we're describing than you might think. There is a lot of supplemental insurance purchased in many countries that have universal care, or there is a lot of working outside the system to get care for systems that don't allow you to purchase that wraparound coverage. So one way or another, either explicitly or implicitly, there have to be limits to what's covered by a public insurance plan if you want to have money left over for other public policy priorities. And that's the tough conversation that we need to have. Not whether healthcare is a right, but how much healthcare is a right.
That's a big shift of a question, isn't it? A very sticky one.
It sure is. It makes people really uncomfortable to postulate that not everybody is going to have the same healthcare, that high-income people are going to get more healthcare than low-income people and have better health outcomes. The reality is that happens now. And there are lots of low-income people or people living in underserved areas who get much too little health care. So having a real conversation about where we want to guarantee access would let us make sure that nobody has care below a threshold. Now, the trick there is defining what we mean by a minimum bundle of health care. I don't mean only cheap care. I mean only high-value care.
Sorry, what does high-value care mean?
High-value care is care that produces a lot of health for every dollar spent. There's some very expensive kinds of care that produce transformative health benefits. That's high value.
Give me an example of that.
For example, there are drugs that cure hepatitis C. People with long-term hep C often need liver transplants, have much shorter, much less healthy lives. If you can cure that, that is an enormous health benefit. That's worth spending money on. And those drugs are expensive, but they're still high value in my book because they're producing such enormous health benefit. Now, on the other hand, there's some cheap care that produces no health benefit. That's low value. Think about antibiotics for viral infections where they're ineffective, MRIs for low back pain where it's contraindicated. There is a lot of healthcare that people get that is of very questionable health benefit. That's low value, and I don't think that we can afford for public insurance programs to cover that kind of care if we want to make sure there are resources to cover high value care for everyone.
There is a question that everybody is listening right now is wondering. It's like, who's paying for this?
So that is the key question, and economists are notorious for being willing to put a price tag on anything. And people say, oh, you can't put a price on your health. But of course you have to put a price on these things or you can't allocate resources effectively. And we care very much about health and housing and food and education. So I keep coming back to saying we need to think rationally about where we want to devote our resources. What's the best use of these scarce resources? Fundamentally, if more people are going to have access to publicly funded insurance, taxes have to go up. And that is one of the challenges, is that the people who benefit from expanded public programs are often different from the people whose taxes are going up. And that creates a real question for policymakers, is how they value those two things. But we would also be shifting some spending away from private insurance spending. So you, taxpayer, might be spending more in taxes, less but not zero in private insurance. But if you are not one of the people who was getting too little insurance before, your total cost may go up. We cannot pretend that this is free. And I think there's a fiction people like to tell themselves that somehow if you cover the uninsured, it's going to make healthcare so much more efficient and people are going to go back to work and they're going to pay more in taxes and they're going to use less healthcare down the road because they're getting so much more effective care now that somehow we'll all save money. My reading of the evidence is that covering more people costs money. They use more healthcare. Someone has to pay for it. And therefore, it has to be a public policy priority to say, we care about the well-being of the people who have inadequate access to healthcare and are willing to pay more, spread across a lot of other people to make sure that that access is improved. We ought not to delude ourselves that that is free.
You do a lot of survey work, even with NORC here at the University of Chicago. What's the American public's appetite for tackling this type of a challenge and being open to a change?
Well, my colleague Amitabh Chandra and I did a survey with the APNORC here at U Chicago, asking preferences about your own health insurance and the health insurance coverage of other people in your community. And we looked at that based on all sorts of characteristics of individuals, including which political party you were affiliated with. And people on both sides of the aisle care about other people's insurance coverage as well as their own, for altruistic reasons, not just because I'm worried about getting diseases from my neighbors, but because I'm actually worried about my neighbors' well-being.
Okay, given that potential appetite for change as our last question, what do you look out and see on the healthcare policy landscape happening over the next 5 to 10 years?
I have to say that I'm not optimistic about wonderful changes coming out of Washington anytime soon. That said, there's a lot of policy activity at the state level, and how you feel about that probably depends on which state you live in and what your preferences are. But I suspect there will be a lot more experimentation with alternative payment systems, with different insurance products at the state level than we're going to see at the national level for the foreseeable future.
Have you ever wondered what goes on inside a black hole? Or why time only moves in one direction? Or what is really so weird about quantum mechanics? Well, you should listen to Why This Universe. On this podcast, you'll hear about the strangest and most interesting ideas in physics, broken down by physicists Dan Hooper and Shalma Wegsman. If you want to learn about our universe, from the quantum to the cosmic, you won't want to miss Why This Universe, part of the University of Chicago Podcast Network.
Big Brains is a production of the University of Chicago Podcast Network. If you like what you heard, please leave us a rating and a review. The show is hosted by Paul M. Rand and produced by me, Matt Hodap, and Leah Caesarine. Thanks for listening.